I think we can get started. Um, I know more people will be joining, but welcome everyone to Geriatric Medicine Grand Rounds. And we are starting to reach the latter part of the academic year. And this is the time of year where each of our geriatric medicine fellows picks a topic on which to present at Grand Rounds. And the first, the first of those four fellows is Shweti Rajagopal, one of our four Jerry Fellows. She is going to be talking about elder abuse, of course, a very important topic. I heard her give a presentation on this earlier this year, and it was fantastic. So, Shweti, I'm really excited to hear your grand rounds and take it away.
Okay. Thanks, Kate. So hi everyone. I'm Shweti. I'm one of the geriatric fellows. My topic today is about elder abuse. I chose this kind of topic. It's because it's pretty common, but not very seen. I feel very often because of how hidden it is. And so I came across this, and I kind of wanted to dig a little bit deeper. And I've got some resources from Dr. Thomas as well as Chris, the social worker at the VA. So let's get started. Um, I wanted to kind of start off with a little case. So this is the case about Mrs. S. She is 78-year-old female with past medical history of moderate Alzheimer's disease, about a fast stage 5. She has major depressive disorder, hypertension, hyperlipidemia, osteoarthritis. She basically comes in with worsening agitation, irritability, and insomnia over the last 6 months. She does live with her adult son, and who helps her around the house, manages her medications, finances, and basically helps her with some of her ADLs and all of her IADLs. She's lost about 15 pounds in the last 2 months, missed about several appointments with her PCP and cardiologist, and overall tends to have poor hygiene during your visit with her. And then multiple medication adjustments have been made in the past for her depression, insomnia, and agitation, and none of them have really provided any benefit for her. She tends to look more withdrawn, anxious, suspicious throughout the visit. You also notice some bruises on her arms, and overall, she's looking a little bit malnourished and dehydrated. Um, I want you guys to kind of think about some questions that you would ask the son or the caregiver in this case, and then kind of keep them in your thoughts, and then we will kind of get back to them a little bit later. Okay. All right. So let's start with, the why. So elder abuse is really common, but most people don't really recognize it right away. It doesn't really come up as someone saying, like, obviously I'm being abused. It kind of shows up in other ways like depression, anxiety, sleep issues, maybe even like behavioral changes. And then this is where we as like geriatricians have a very unique vantage point. We kind of see these patients over time, we meet them alone, we notice like subtle changes in mood, behavior, or even social interactions. And then these longitudinal relationships that you kind of build with a patient are kind of key. Even like small patterns, such as, a patient becoming suddenly withdrawn, anxious, hesitant around a family member, can kind of be red flags. So why is this kind of important? So, because if we don't really notice any of this, it can go on for months or years, and overall, the health consequences, both physical and psychological, can really be devastating. And as clinicians, we kind of have the chance to step in early, sometimes even when really the patient can't really advocate for themselves fully. Um, so, what counts as elder abuse? The definition is much broader than what a lot of people think. It's not really just hitting or yelling. It can be neglect, like failing to provide basic care, or even acts that put an older adult at serious risk. Importantly, it can happen anywhere, at home, in the community, or even in like institutions such as like adult family homes, nursing homes. In the US, when I was looking it up, about 10% of older adults experience abuse every year, but that's almost certainly like an underestimate because of just how much underreporting happens. And this tends to happen because a lot of fear, shame, dependence on the caregiver's language or cultural barriers, or just overall cognitive issues are associated with this. And patients with cognitive impairment are particularly vulnerable, especially to emotional abuse and neglect, because they may not be able to speak up and remember incidents very clearly, or just so a lot of times they're not really believed if they do. So this is something, this was a brief case that from Redmond, Washington, back in like 2013. Dr. Thomas and Chris were kind enough to, bring this to my attention. So when I was looking into it, this is basically a 65-year-old daughter. She had power of attorney over both of her elderly parents. Her mother was, I think, 89 and her father was 92. And she was arrested for like severe abuse and exploitation of her parents. And then when they went in and tried to investigate the case, it looked like the mother had been like physically restrained in like a homemade cage like structure that she kept the mom in all day, and then strapped her to a wheelchair like during the day so she couldn't get up and move around. And then both parents were like denied food, medications, and care. But at the same time, the daughter was also suspected of kind of stealing over like $67,000 from their accounts, money that they had kind of saved up for like their retirement and like when they grow older. And so it was a little very sad case, but very interesting. So yeah, if anyone's interested, you definitely should look into it or read into it. Um, so to give a sense of how widespread elder abuse really is, this is a recent review that came out sometime in July of 2025, I believe, and it's by Catal and colleagues. And they basically took data from like 94 studies across like 35 countries. And what they kind of found is pretty striking, and looks like worldwide about 1 in 4 adults experience some form of abuse. And then if you break it down further, emotional or psychological abuse is the most common, about 21%, and then followed closely by neglect, which is 19%. And then, interestingly, abuse tends to be a little bit more common in institutional settings than in the community, which kind of, is puzzling because you would think that it happens, more in the community. But yeah, but that was kind of interesting to me as well. And then sexual abuse obviously was rare in the data, only about 1.5%, but that's probably because it was very heavily underreported. And then I think this review kind of highlighted 2 points. First, obviously, elder abuse is global and pervasive and not just like a local or rare problem. But second, most of it isn't really physical, but it's very much so like just subtle, emotional, and neglectful. So it's something that we really have to be looking into carefully. During our visits. Okay, so the next thing I wanted to kind of get into are just like the clinical impact and consequences of abuse. Elder abuse, it has obviously serious effects on patients' health, but on top of that, we also tend to see increased hospitalizations, earlier placement in nursing homes, and unfortunately, like higher rates of premature death. Just if you I guess you should just think of chronic abuse as like a type of ongoing toxic stress. This stress can kind of accelerate cognitive decline and worsen overall psychiatric illnesses as well. So, if we miss the abuse and just kind of keep treating anxiety or depression without really asking what's happening at home, we a lot of times, medications are often escalated. They're refer to psychiatry inappropriately, or interventions are just added on that don't really address like what is going on like on the bottom, on the surface. And then why is just the next thing I wanted to kind of get into was why it's kind of often missed. These kind of seem pretty much kind of common sense actually, but it's just that it's there's just a bunch of practical barriers. I feel like a lot of times many physicians, clinicians, staff aren't really receiving specific training on how to recognize these signs. A lot of them are very busy in clinic. It's just, and they're overwhelmed with so many other things, so many other problems they have to get to during their visit. So there's a lot of time constraints in a busy clinic day, making it kind of harder to dig deeper. Another big factor is that patients are often not always interviewed alone. And then if a potentially abusive caregiver is kind of in the room, they might not really feel safe to speak. And that is kind of a worry because, a lot of times it can be missed. The other thing is there's a lot of concerns about like, going into this kind of might upset the family or damage the physician family relationship. And then finally, I think a lot of us are just not really confident about how to report suspected abuse, who to call, what protections exist. So even kind of with the best intentions, these barriers can kind of make detection risky. So there's a couple of risk factors for elder abuse that I think kind of heavily weigh into when this kind of happens. On the patient side, dementia or cognitive impairment is the strongest risk factor, but severe mental illness, physical disabilities, functional dependence, social isolation, language barriers, and low health literacy all kind of play a role. And it's not just about the patient, it is also about caregiver factors matter a lot too. So high caregiver burden, burnout, untreated like psychiatric illness or substance use in the caregiver, or financial dependence, and just like lack of social support and a personal history of interpersonal violence in the caregiver itself also is raises red flags. So when you're kind of looking into all of this, you kind of want to consider both sides of the relationship, both how vulnerable the older adult is, plus the stressors that the caregiver is also going through. So there's different types of abuse that we kind of know, and abuse. I feel like this picture on the side kind of shows it even a lot more, which I didn't really go into. It kind of went into like the most common forms of abuse that we see, which are emotional or psychological abuse, neglect, including self-neglect, financial abuse, physical abuse, sexual abuse, and then institutional abuse. Um, I there's significant overlaps also between these different categories, and then this kind of this picture on the side actually is from the Care Act of 2014 from United Kingdom or UK. So in I kind of put this in because I kind of liked what this act was about. So in the United States, a lot of care for older adults, it's highly fragmented. Medicare and Medicaid kind of cover different populations, different services, and then like social care, like home health, APS, or like community programs, they kind of operate separately. And then older adults in our system kind of see multiple providers who don't really communicate effectively. And then this fragmentation of the care kind of leads to gaps in care, delayed interventions, missed signs of abuse. But in 2014, UK's Care Act kind of tried to unify all of this care in one place. The local authorities of like the UK, basically, they coordinated social care with health services and assessments. They're very person centered, covering both medical and social needs. Multidisciplinary teams, including like physicians and social workers, kind of all work together. And then there's also like these boards that are kind of for safeguarding that kind of investigate suspected abuse promptly. And then this like integration of all these teams working together kind of reduces the gaps and ensures like the elderly kind of receive continuous coordinated support, and nothing gets really missed. So going into the different types of emotional or psychological abuse, emotional abuse is kind of one of the most under-recognized forms of elder mistreatment, like we mentioned earlier. It's largely because it leaves no physical signs. It involves behaviors more like verbal aggression, humiliation, intimidation, and or controlling actions, just kind of like by a caregiver or a family member. And then these interactions are more subtle, more chronic. They're often normalized both by caregivers and even sometimes by the patient themselves, making it kind of easy to overlook. However, the psychological impact of this emotional abuse is pretty significant. A lot of them tend to develop depression, anxiety, insomnia, and just like a persistent sense of fear. And then in those with dementia, it can kind of manifest as like worsening behavioral symptoms, including agitation or withdrawal. And then over time, repeated exposure can kind of lead to learned helplessness, where the individual kind of feels powerless to change their situation. A lot of them tend to lose their autonomy. And then a lot of them develop a state of like chronic hyperarousal, meaning they're constantly on edge or nervous. And then it's also important to recognize that emotional abuse like rarely occurs in isolation. It often occurs with coexists and overlaps with other forms of abuse, especially neglect or financial abuse. So neglect refers to the failure to meet an individual's basic needs, such as food, hydration, medical care, medication management, and overall just safety. It can be intentional, but more often it actually occurs due to caregiver stress, lack of resources, or just limited understanding of like what the patient needs. It is kind of important to kind of approach these situations with a nuance, as not all neglect kind of comes from a malicious intent. Self neglect is a subtype of neglect where patients are kind of unable to care for themselves due to cognitive impairment, psychiatric illness, or physical limitations. They're especially common in older adults with dementia or severe depression. And then clinically, neglect can kind of present in several ways: unexplained weight loss, dehydration, poor hygiene, pressure injuries, missed appointments, and medication non adherence. And then from a psychiatric standpoint, they may develop like delirium, depression, apathy, agitation, or overall functional decline in function. And then a lot of these, it's really important to kind of um, um, find these like, early, because neglect often progresses gradually and it can kind of lead to significant morbidity if left completely unaddressed. Okay. All right. So physical abuse. This kind of involves the use of force that results in any pain, injury, or physical impairment. It includes actions such as hitting, pushing, inappropriate restraint, rough handling, or even kind of misuse of medications for sedation. It is important to remember that physical abuse also often overlaps with emotional abuse and neglect. So when you identify one form, trying to identify other forms should also be something you should be looking into. And then there are several key physical findings that should raise concern. Bruises in atypical locations, such as like the torso or inner arms, injuries at like different stages of healing, specific fracture patterns like posterior rib fractures or distal ulnar fractures. These can kind of occur when somebody's trying to do defensive movements. And then other red flags are like subdural hematomas without really a clear history of trauma, as well as burns or marks from restraints. And then behaviorally, a lot of these patients tend to appear more fearful, avoid certain caregivers. They become really protective and or withdrawn. And then sexual abuse in older adults. This is basically any non consensual sexual contact ranging from inappropriate touching or coercion or assault. It's one of the most underrated forms of abuse, largely because of the stigma and the associated shame, fear, cognitive impairment, or just inability to communicate. Um, Psychiatric and behavioral changes are actually like the first clues. A lot of them tend to exhibit sudden changes in behavior. They express a lot of anxiety, agitation, withdrawal, and then a lot of them have like PTSD like symptoms, like nightmares, just screaming and things like that. And then because of how sensitive this topic can be for patients, it's really important to kind of talk to them in like a very safe and private and non-judgmental environment. Yeah, it's very critical. You all these things are kind of addressed when you're suspecting sexual abuse. And then financial abuse involves the illegal or improper use of an older adult's money, property, or assets. Um, this can be just like outright theft or just misuse of power of attorney, manipulation, or just restricting the patient's access to their own finances. Several red flags to watch for. These include sudden or unexplained financial changes, inability to kind of afford the medications, even though they were able to afford it before. Um, Unpaid bills, abrupt changes in like legal documents such as wills or power of attorney. A lot of patients tend to express a lot of confusion about their finances or tend to become anxious when you kind of bring this up. Yeah. And then lastly, institutional abuse refers to mistreatment that occurs within nursing homes, assisted living facilities, or long-term care settings. Um, Unlike individual caregiver abuse, this is kind of often driven by like systemic issues such as understaffing, inadequate training, staff burnout, and just broader organizational failures. And then these factors kind of create environments where neglect also happens often. And then red flags include like unexplained injuries, malnutrition, dehydration, oversedation, and then frequent hospital transfers, and then just like inconsistent communication from staff. And then you can also notice like delays in care or lack of attention to like basic needs of these type of patients. And yeah, and it's kind of just really important to recognize that even like intentioned staff can kind of contribute to suboptimal care when there's a lot of strained systems kind of happening in place. And then this was a study that I found. It was actually in 2021. It is from the Journal of Clinical Medicine, which kind of looked at elder abuse during the COVID-19 pandemic. And it's actually in Poland, actually. It assessed 347 patients, about 65 and older, at a geriatrics and a neurology clinic in Poland. And they used questionnaires, the vulnerability to abuse screening scale, and then they also used the GDS, or the geriatric repression scale. And they kind of found that nearly 45% of participants reported some form of abuse during the pandemic, with psychological abuse being the most common, followed by neglect, physical, and then financial. And then a lot of the risk factors that they kind of saw in the study were that a lot of these patients were from low income families, they had chronic illness, poor family support, depression, functional impairment, and a lot of them even had a history of COVID-19 infection, which kind of obvious. And then screening also identified nearly half of these participants were at risk, even if they hadn't reported any abuse directly. All right, and then this was actually an interesting pie chart that I found. So when we think of like perpetrators of abuse, adult children make up by far the largest group, about 40%. That's not really because adult children are inherently abusive, but more because they're the ones often providing care to these older adults, managing finances, living with the older adult. Spouses are also the next largest group. This is especially relevant because illness, frailty, cognitive decline can kind of destabilize like long-standing relationships. A lot of caregiver stress gets involved, mutual dependence, and just a lot of unaddressed health issues on both sides can kind of already cause more strain. And then what's really important to kind of I thought was interesting was kind of just like looking at the cumulative effects of the extended family. And then when you add siblings, grandchildren, parents, and other relatives kind of into the picture, you kind of see like multi-generational involvement that plays a significant role. And then this is because a lot of these patients tend to share housing, financial strain, or just like there's like a lot of unclear like caregiving responsibilities between these patients, and all of this causes an increased risk. And then uh, so the key takeaway from this like slide was basically elder abuse. It always involves someone that the patient depends on, and then that dependence kind of makes disclosure incredibly difficult. And then yeah, and then for us as geriatricians, we kind of need to look at the importance of kind of routinely asking about the caregiving arrangements, caregiver stress, and who actually is managing day-to-day care. And if we don't kind of ask this, patients kind of rarely will speak out and give this information to us on their own. Okay, so now going back to the case, uh, if somebody could unmute or kind of put in the chat, I don't have access to the chat, but just kind of going back to Mrs. S's case, what questions you would ask the son?
Shweti, do you think you could put it back on the slide with the case in case folks weren't here at the very, very beginning?
Yes, let me go back. Oh, oh, will that work?
Great. All right, now folks can ask questions. All right, so one Jacqueline mentioned asking how she got the bruises, so asking about the bruises.
Mm-hmm. Yeah. I can kind of go back to where I was. Okay.
And then the next comment is Elizabeth said she would explore caregiver burden.
Yeah, those are all great questions. Um, for the sake of time, I can kind of go into it. So I just kind of put together a list of things that I thought, are good questions to kind of ask the caregiver. Obviously, caregiver burden, and asking how they got the injuries is definitely a significant part of the questioning. I think to add on to that, I think definitely just asking what a typical day, is for the patient, how she takes her medications, how often does she eat, and then how obviously she got those bruises, has she had any falls, and just looking into kind of how often the caregiver or the son is stressed out, and then or how stressful it is for the son to take care of her, and then how often she gets agitated and things like that. And then also some questions to ask the patient. If she is able to answer, she does have a FAST stage of 5. But just like basic questions to ask her to kind of get a sense of how safe she feels at home with her son, and just possibly if she knows how she got those physical injuries, and then what help she gets around the house. How is her money managed? Is she getting enough food? These are just some questions. Obviously, there's no right or wrong answer to kind of go about this, but these are just some questions I thought of to kind of to access or to get some more information from the son and the Mrs. S. Okay, so this is kind of like the next few slides are kind of getting into like more of a clinical approach when suspecting elder abuse. So one of the most important first steps is kind of prioritizing private conversations with the patient, kind of repeatedly over time. And then disclosure often does not really happen in a single visit. So building trust is key here. During these conversations, like we had mentioned, open-ended, non-judgmental questions about just routine, and instead of asking directly about the abuse, we can kind of explore like daily routines, like those previous questions, or just caregiver relationships and how decisions are kind of made at home. And then a critical component is assessing a patient's decision-making capacity, but this should be task-specific, meaning we should evaluate like their ability to make decisions about living situations, finances, medical care, kind of individually. And then careful documentation of this is recommended as well. And then we should also gather collateral info from multiple sources if we can, from like multiple family members, caregivers, prior records, and even just like pharmacy data to see how many refills and things like that. That can also provide us with a lot of information. And then documenting what we observe, like the physical findings, behaviors, affect, and then just interactions between the caregivers also is helpful. And then finally, before labeling the situation or confronting the caregiver, we kind of need to assess the risk and develop a safety plan. Kind of acting too early sometimes can put the patient at danger, and this is not the best scenario. Um, Going into several red flags that we had kind of already discussed, but just to touch base really quickly, when you're thinking about like recurrent ED visits without really a clear diagnosis, this can kind of indicate like an underlying unresolved issue, like unsafe living conditions. Similarly, delays in seeking care, particularly for any serious conditions, can kind of suggest neglect, or just caregiver barriers. And then just inconsistent history between the patient and caregiver is just another major warning sign. When stories don't really line up, it is important to kind of further explore into what's going on. And then obviously missed appointments, medication discrepancies can also reflect like poor supervision or intentional withholding. And then from a functional standpoint, a sudden decline in independence should always prompt further evaluation, especially if it can't be like medically explained. And then dehydration, malnutrition, chronic disease, chronic disease control, and then just like recurrent infections also signal poor health, poor hygiene, inadequate caregiving, or unsafe environments. This, I know it's a lot on this page, but basically it is just some key tools for screening elder abuse in the home or community. And this is kind of like a global, I tried to make a little chart of basically a lot of there's a lot of screening tools in different countries, and kind of try to pick out like the most common ones that I saw. The first one, the Holick Sangstong elder abuse screening test, is actually an interview-based tool. It's designed to kind of identify older adults at high risk, focusing on their rights violations as well as how vulnerable they are. And then the VAS is actually a really good screening tool used in older women. It is a 12-item self-reporting tool that kind of assesses their dependence, any coercion, and then just any there's some validity kind of that was actually found with this screening tool as well, but it's really good for especially the older women population. And then the EASI, the Elder Abuse Suspicion Index, is the one that I mostly saw, but it is for it's like a 5 patient directed question, and it has like one clinician observed item, and it is the one that a lot of social worker assessments have used, is what I saw, and it helps identify like the victims pretty efficiently. And that's the one I think a lot of from my research, it looks like a lot of social workers and things like that in the U.S. and Canada tend to use this one. And then there's also some caregiver focused tools. Uh, the case and the caregiver psychological elder abuse tool kind of assesses abusive behaviors from informal caregivers, focusing on physical and psychological behaviors. And then finally, base is a 5 question professional administered tool that kind of looks through multiple abuse domains and has also, I think, a strong reliability as well. And then obviously there's a lot more, and there's obviously no universal gold standard, but using these kind of tools can, along with just what you see in clinic, is really good to kind of help improve detection and intervention for elder abuse. All right. Just some interventions that we're going to get into. So the next steps, when you obviously suspect abuse, the priority kind of shifts immediately to ensuring obviously the patient's safety. The patient should always be kind of, like we had said, should be interviewed separately from the caregiver when possible, just to allow for honest communication. A key question to kind of ask ourselves is this patient safe to go home today? If the answer is no, then we need to kind of act on by admitting them to the hospital or arranging alternative placement. If you find them to be in immediate danger, then obviously emergency services should be contacted like right away. And the second thing is obviously, do they have capacity? Do they kind of understand their situation, the risks they face, the options available to them? And if the patient has capacity, do they have the right to refuse help, even if we disagree? And in this, if they do have capacity and they refuse, and we may still be obligated to kind of report our concerns. But if the patient lacks capacity, then we need to kind of involve a DPOA, a power of attorney, just or pursue guardianship. But at the same time, we should also be medically stabilizing them, treating their dehydration, malnutrition, just evaluating and treating their injuries, and just reconciling their meds. Um, for documentation, you should document objectively what you see, physical findings, size, shape, location of the injury. Anytime a patient makes statements, those should be quoted directly whenever possible, as this can kind of be important for legal processes. It is also important to document the caregiver explanations and any notable behavioral observations, and just you should avoid making assumptions or drawing conclusions when you are documenting suspected abuse. And then mandatory reporting is another essential step. In most cases, this means reporting obviously to APS. We will get into this a little bit more, but it is important to kind of remember that you only need reasonable suspicion, not definitive proof, to make a report. And then finally, just early involvement of multidisciplinary team is key. Just involving social work, case management, nursing, even sometimes psychiatry is important, because these teams can kind of play a crucial role in safety planning and coordinating resources, and just kind of helping deter appropriate placement options. And then safe discharge planning is one of the most important parts, I think. It's just, where will the patient be the safest? Obviously, there are options with returning home with additional support, home health services, or utilizing like adult daycare. And then in some cases, obviously, they can go to SNF, assisted living, or even living with an alternate family member. This can be an appropriate option because they might provide a safer environment. And then you should also not forgive, like, obviously, the caregiver factors, just because not all situations are malicious. Some do just come from because the caregiver is so stressed out. And in these cases, providing support can make a significant difference, especially like you can provide them with respite, home health aides, caregiver support groups, and even just education on dementia behaviors and how to manage these. And then lastly, I think just implementing risk reduction strategies, such as just like simplifying their medication regimens, arranging meal delivery, like Meals on Wheels, increasing supervision, and just modifying the home environment to kind of remove hazards kind of can also help prevent further harm. Um, so this is mandatory reporting and APS. Obviously, this is a big part in going about how to, take care of elder abuse. Like I said, in most states, reporting you can report when you just suspect it. Not it doesn't have to be proven. And this is actually the reason that is, you can just do it when you suspect it is because it can prevent like delays in interventions and prevent putting patients at further risk. And then once an APS report is made, APS becomes involved. They play a very supportive role. They kind of evaluate the patient's safety, assess the home situation, coordinated resources such as like social services, legal support, healthcare assistance. And then, but the one thing that they don't automatically do is remove the patient from their home, and their goal is to kind of preserve autonomy whenever like is possible for the patient. And then reporting, it also kind of helps us because we're fulfilling our like legal and ethical obligations, but we're also kind of just creating a documented pathway for intervention for these patients. And then this slide is just like the steps of what APS kind of goes into. They obviously, I think, if you have reported abuse before, they usually take a phone intake by the phone, and then they will assign APS worker to kind of look into the case and then investigate, and then they will come up with a list of services that they can provide for the patient. And then this was a little notice that Dr. Thomas actually kind of brought my way as well. So in Washington State, actually, there are very clear expectations for long-term care facilities when there is concern for elder abuse. And this process is kind of work closely alongside the ombudsman. And then, so basically, healthcare professionals and facility staff are actually considered mandatory reporters. That means if you have any reasonable cause to believe that abuse, neglect, abandonment, or any financial abuse is occurring, they are legally required to report it, even if they don't have proof. And for residents living in like long-term facilities, such as like nursing homes, assisted living, adult family homes, they are directed to something called the state's residential care unit service complaint resolution unit. And this is kind of the body that kind of oversees the facilities and investigates complaints. And then they can either make these complaints through the phone, like there's an online triaging system. Then the reports are screened, triaged, and then investigated. And then if there is any, obviously, concern for any like sexual harm or physical harm, then you need to call the law enforcement to involve them. And all of this can kind of happen through the ombudsman, and they're very good at coordinating this. And so I just thought I would add this in to kind of give that. And then lastly, these are just other interventions that you could do just beyond reporting. There are some patient-centered interventions that you can do, like home safety environments, like OT home, like OT will go and like assess the home. And then you can look for like fall hazards or unsafe living conditions and kind of just otherwise be misinterpreted as neglect, and they can kind of go in and kind of see how they can modify their houses. And then you can also do regular check-ins with like nurse or social worker visits, and this can kind of provide like ongoing monitoring and kind of early identification of these concerns. And then I thought another thing we should also focus on is just empowering the older adults, encouraging autonomy, decision making, ensuring access to their own financial and legal resources can also reduce how vulnerable these adults are and also improve overall well-being. And then on a broader level, um, routine screening for abuse in primary care can help normalize these conversations and increase detection. And then, just like in the health record, when you are concerned for a high flag alert, you can put flag high risk alerts, and kind of someone with cognitive impairment who's also socially isolated, this can also be taken as a proactive measure. And then lastly, I wanted to kind of go into support programs that are available. Um, the START program is it is stands for Strategies for Relatives. This is an evidence-based intervention worth highlighting because it is a structured program designed for caregivers of older adults who are in the community, particularly those with dementia or functional dependence. The main goal is to kind of reduce caregiver stress and improve like coping strategies. And this is critical because caregiver burnout is probably one of the biggest risk factors for both intentional abuse and unintentional neglect. And then this program consists of 8 sessions. It's delivered by trained therapists, and they focus on psychoeducation, stress management, problem solving strategies, and just relaxation techniques. And it is also flexible on how it's delivered. It can be done through the phone or through home visits. And another component is that it encourages caregivers kind of build and use social support networks, which can kind of significantly reduce isolation and stress. Another key resource is the area aging agencies on aging, which are funded under the Older Americans Act. These agencies, which I think some of you guys might have seen them around, there is one in Seattle. I think there's like 2 in Seattle, and then are basically designed to kind of help older adults maintain independence, dignity, and overall well-being. They serve kind of as like a bridge between patients, caregivers, as well as like the community. And they actually provide a lot of key services. They help with respite, education, support groups, programs like Meals on Wheels. They provide meal services that kind of make sure that these older adults have consistent access to healthy food. They also provide personal care assistance, transportation, even like home modifications to improve safety. And then one cool thing is that they do help with like finding powers of attorney, advance directives, and just financial protection for the older adult. And then they also do fall prevention classes and chronic disease management programs, which is also kind of unique. And then this is the guide model, something also Dr. Thomas kind of brought to my attention. So it is developed by the Centers for Medicare and Medicaid Services Innovation Center, and it focuses kind of on improving dementia care for Medicare beneficiaries. So it stands for Guiding an Improved Dementia Experience, and it was created kind of in response to the recognition that dementia care in the US is often very fragmented, like we had mentioned earlier. And there tends to be a lot of poor coordination between healthcare providers and significant reliance on informal caregivers. And this model kind of uses interdisciplinary teams, including physicians, nurses, social workers, to kind of create standardized, comprehensive care plans. It also kind of emphasizes care coordination across multiple settings in helping kind of patients kind of transition more smoothly between outpatient care, hospitals, home. And then a major focus of this model is just caregiver support. It helps educate the caregivers, provides respite services, and It also provides 24/7 access to care support, which can help address any issues early and also reduce unnecessary emergency visits or hospitalizations. And then the overall goal is to kind of just improve the quality of life and outcomes for the patient, reduce caregiver strain, and just overall lower healthcare costs by preventing complications and kind of just improving coordination. And then lastly, this is another caregiver support program called Reach 2. Stands for Resources for Enhancing Alzheimer's Caregiver Health. It is kind of a multi-component program. It is specifically designed for caregivers of patients with dementia. And then it focuses on providing like individualized counseling, skills training, and stress management techniques for the caregivers. And what kind of makes this program unique is that it is tailored to the caregiver's specific needs and helping them develop more practical strategies to kind of manage difficult behaviors, reduce stress, and overall just uh, improve their caregiving capacity. And then this is the last thing. This is a little platform. It is a global initiative from the World Health Organization, and it's for called the AOPIA. It stands for an intervention accelerator to prevent abuse of older people. So basically, it's elder abuse, is really common, and this kind of what's really cool about this is you can kind of, when you suspect abuse, you can kind of put in like what kind of abuse you're suspecting, and whether it's happening at home, whether it's happening in the community, and they can kind of uh, build like they'll pull up a bunch of articles of how different interventions you can try on for the patient. So I played around with it. It had some pretty cool interventions that are unique to the scenario. It's a little database, and basically it takes all the research and from different countries and kind of gives you like a um, specified detail set of like which interventions to use for which type of abuse. Um, yeah. And then lastly, I think these are just some takeaways today, that abuse is pretty common. It's often not often hidden. It affects 1 out of 6 people globally and very frequently underreported. And then screening alone is kind of not enough. There's a lot of clinical suspicion matters. No perfect tools exist, but it does require observation, collateral history, and just asking the right questions. And then you, as geriatricians, kind of play a critical role in detection and protection. And early recognition and reporting can prevent serious health harm or health. Yeah. Okay. Thank you. Any questions?
Thanks so much, Shweti. Please fill out evaluations, folks. Yeah, thank you so much for that. There were a couple comments in the chat. I'm not sure if you can see it, but if not, um, while you were talking, May Reed reminded us all that Adult Protective Services requires that the patient meets the definition of a vulnerable adult, and in order to report to APS. And essentially, like bottom line, that's someone for older adults, it's someone 60 or older who needs help from someone else for physical, cognitive, functional abilities that they can't do all of those independently. So you have to certify that in order for them to meet that criteria. And then Rima pointed out,
Kate,
oh,
yeah,
yeah,
can I give my quick example? Yeah,
oh,
so this
sure.
was a very medically complex but cognitively intact gentleman who had just bought a two-bedroom condo to protect himself from Medicare. And his son moved in and would not move out and was financially exploiting him. And I reported multiple times to APS. The son had substance abuse and mental health problems, and APS said, you note in your notes that he independently does his ADLs and that he is cognitively intact. He is not defined as vulnerable. So it was yeah, it was very difficult. Yeah. But anyway, interesting. I learned a lot from that.
Thank you, May. Really important to point that out. And then Rima, I don't know if you wanted to unmute for your comment.
Oh, it's just, I think, thank you, Shweti, for highlighting how sadly common this situation is. In my short career, I've already had a few really heartbreaking cases. And a sticking point that has been on my mind in this time is there have been cases where the adult is obviously in a really dangerous situation and sometimes I know that we are balancing autonomy and patient dignity, and I'm not trying to negate that, but there are situations in which I've wished that APS could whisk that adult out of that dangerous situation while the investigation is going on, like Child Protective Services might do in a situation very similar. Um, and APS cannot do that, and sometimes I wish that they could.
Yeah.
That's my point.
Thank you, Rima, for sharing that. Elizabeth is asking, Shweti, if you've come across any screening tools that have been developed for interviewing people with cognitive impairment or dementia.
Um, I think I think the just that one, I'm gonna go back to that slide, sorry. I think just I think there was one that I did see, which I didn't because it wasn't very used. But I think the vulnerability abuse screening scale (VAS) can also, even though it's used for women, I think it also has a component of dementia in there as well. Um, but nothing particularly that I came across that was used very frequently for just dementia. But that is a good question, and I think that is something I could look more into.
Any other questions or comments? Oh, Elizabeth says that's a research opportunity. We're always looking for those.
Yeah, for sure.
Well, thank you so much for this great presentation. You covered quite a bit and pointed us to some new tools. I'm very excited about this Decade of Healthy Aging website. I am checking it out at the moment and it's really cool. So thank you for sharing that with us. And yeah, thanks for reviewing this really important topic. And everyone, thanks for your interaction. I hope you all have a wonderful weekend.
Thank you.